Hello and welcome to this RPTH research recap, where we dive a little deeper into the science being published at RPTH. My name is Aurélien Deluc. I'm a member of the RPTH editorial board. I am a thrombosis physician and scientist with the Department of Medicine at the University of Ottawa in Canada. I am pleased to be your host today and to introduce Dr. Luca Valerio. Dr. Valerio studied medicine at the Catholic University of Rome, Italy, pursued a PhD in vascular epidemiology at the Academic Medical Center of Amsterdam, the Netherlands, and is now virtual fellow and resident in internal medicine and cardiology at the Center for Thrombosis and Hemostasis in Mainz, Germany. He recently published a paper in RPTH entitled Global Reporting of Pulmonary Embolism-Related Deaths in the World Health Organization Mortality Database, vital registration data from 123 countries. He reported on global PE-related mortality and its association with country income. Dr. Valerio, we look forward to hearing your presentation.
Thank you for this invitation to present my research. Thank you for your introduction, Dr. Deluc. So I'm Luca Valerio. I am a research fellow and resident in cardiology in Mainz, Germany. And I'm going to briefly introduce this recent analysis that we're happy to publish on research and practice in thrombosis and hemostasis. This was an analysis on the global reporting of pulmonary embolism-related deaths derived from data from the World Health Organization. And it was quite a large-scale analysis meant to assess the burden of mortality from this condition, pulmonary embolism. I have no conflict of interest in relation to this topic, and a little background on why this is a challenge for research currently. Mortality from pulmonary embolism. It is quite surprising that until a few years ago, there used to be no reliable estimates on mortality from pulmonary embolism. And this is because pulmonary embolism is quite an unusual cardiovascular disease. The most interesting problem is that it is considered often by clinicians not to be a primary disease that can cause death, but rather a complication of other diseases. Most clinicians working in internal medicine, in cardiology, in pulmonary medicine know very well that several cases of pulmonary embolism, the majority of the cases of pulmonary embolism, actually complicate other major conditions such as cancer or orthopedic diseases, trauma, surgery. It can also be a complication of physiological conditions such as pregnancy. But this makes it very difficult to actually estimate how many people die from pulmonary embolism, because in vital registration data, in death certificates, it is often the case that the other condition is reported as the primary cause of death. So this is the major problem in the last few years we've been dealing with in estimating mortality from pulmonary embolism. It doesn't help that this condition is tackled in different countries by different specialisms. In some countries, it is a cardiological disease. In other countries, it's in the realm of pulmonology. In other countries, it is handled by hematologists because, of course, it is a thrombotic disease that requires anticoagulation. This makes the condition fascinating and complex, but it doesn't make it easy to collect reliable data. And the problem of misattribution of cause of death is also particularly evident in pulmonary embolism. Clinically, very often sudden death from pulmonary embolism is attributed to myocardial infarction, to more evident causes of death. And autopsy would be the most reliable way to attribute more death to pulmonary embolism. But of course, autopsy is conducted not so often nowadays. In the last 20 years, we have witnessed a progressive standardization of the classification of causes of death, and in particular, the 10th edition of the WHO International Classification of Disease has spread widely across the world and has provided more opportunities to obtain accurate estimates of mortality from different conditions, in addition, including pulmonary embolism. And over the last few years, several consensus statements from the ISTH have also addressed the problem of attributing death to pulmonary embolism And the notion that several deaths attributed to venous thromboembolism, the general category to which pulmonary embolisms belongs, has been introduced. And in our opinion, it has helped our ability to estimate death from pulmonary embolism. In previous analysis from our research group here in Mainz, Germany, we have also used WHO data to estimate recent trends in mortality from pulmonary embolism, but only from selected area of the world. This was an analysis from the WHO European region that showed how, based on vital registration data, the mortality from pulmonary embolism has been decreasing, which is good news, of course, even though it is unclear why we have been witnessing this. I want to draw your attention to the right panel. You see how the very clean line to the left actually derives from very heterogeneous estimates from different countries, which is a very important reason why we conducted our analysis on global PE mortality. In a subsequent analysis, we also showed that, again, focused on specific countries, in this case, the United States and Canada, that this decreasing trend was consistent. And we also found worrying trends showing that probably the decrease in mortality already stopped in the younger age groups. This is what led to our attempt to broaden our scope to the global situation. And of course, we have this instrument that in the last 20 years has increased in its accuracy, the WHO mortality database that collects, using standardized administrative flows, the death certificates from all countries in the world. Of course, more and more countries over the last 20 years have been contributing to this data flow. However, this analysis was relatively complex because, of course, in order to calculate age-standardized mortalities, we also need population data, which we drew from the United Nations data sets. And we also wanted to check whether there were association with income levels across countries. And we derived this information from the World Bank data. So we merged information from several large data sets. And in the end, we decided to, in order to maximize the accuracy of our estimates, to focus on countries that used the latest standardized iteration of the International Classification of Disease for their death certificates. And it was, of course, the 10th edition. And of course, we focused on the latest data produced since 2000. We were able to produce estimates from the 6 WHO world regions, and also separate estimates for countries of different income groups, which substantially improves our estimates compared to our previous research, which was focused on high-income countries. As you can see, half of the countries in this analysis were not high-income countries. And this is quite novel in the field of clinical epidemiology of pulmonary embolism. What we found is that less than 1% of the total deaths in the most recent years per each country were attributed to pulmonary embolism. This is consistent with what we know about proportional mortality from pulmonary embolism. Indeed, in most countries, less than 1% of deaths are attributed to pulmonary embolism. The age standardized mortality, which we had estimated in the latest 5 years between 5 and 7 deaths per 100,000 population years in Europe and the United States, varied much more widely in these estimates. This was expected, and we had countries with no reported deaths from pulmonary embolism, especially very small countries, and countries with up to 24 deaths per 100,000 population, substantially more than 5 to 7. But the association with age, which is very well known from clinical epidemiology of venous thromboembolism, is very evident. You can see here a screenshot of our detailed results, and you can obviously see that our findings confirm what we already know from clinics, that the association with age is exponential in venous thrombosis. And this regards both incidence and, as in this case, mortality. We were able to produce what, to the best of our knowledge, are the first cross-country comparisons in estimating PE mortality. And of course, it is very important to provide separate estimates for women and men, as we know that in venous thrombosis, persisting sex differences exist. And we were able to find them even in this analysis. But more importantly, you can see very clearly that there are differences across countries in the estimated mortality and across continents, with generally higher estimates, in particular for Southern America, lower estimates for high-income countries, Northern America and Europe, and quite considerable sex differences in the Middle East. One of the most novel approaches for this analysis was to check whether the estimates differed across income groups. And we found indeed a statistically significant association between the income level as defined by the World Bank classification in 2009, so on objective and standardized data, and the estimates of age-adjusted mortality, even though the association was quite weak in terms of effect size. So there is more behind the differences we observed, but income may be a part of it. The same applied to proportional mortality from pulmonary embolism, that is not age-standardized mortality, but rather the proportion of all deaths explained by pulmonary embolism. So our conclusion is that we have now more instruments compared to 10 years ago to estimate mortality from pulmonary embolism, and we are enjoying a good moment in research of convergence of definitions, both standardized definitions, clinical definitions such as the ISDH ones, and definitions of causes of mortality as provided by increased adherence to the International Classification of Disease Stratification. However, heterogeneity is still a problem. And we believe that this mostly originates from the lack of awareness, not only in the general public on pulmonary embolism, as shown by several polls on what is pulmonary embolism and whether pulmonary embolism can cause death, but also in the scientific community, because it is still an important question how reliable the filling up of death certificates by clinicians around the world. And we believe that our ability in the future to estimate the burden from pulmonary embolism will greatly benefit by increasing awareness on the burden of pulmonary embolism and its clinical importance. And initiatives such as those represented by the World Thrombosis Day will play a key role in increasing this awareness. Thank you for your attention.
Thank you very much, Dr. Valerio, for this great presentation. So we have now time for a few questions. And the first question I have for you is maybe a more personal question. What led you to this project? Is it part of a larger research program that you work on?
Yes, thank you. So until a couple of years ago, our research interests in venous thrombosis were limited to clinical epidemiology. However, we realized that to our surprise, until 2017, 2018, there was a lack of reliable data on pulmonary embolism mortality. This is in sharp contrast with other well-studied causes of death, such as myocardial infarction or cerebrovascular diseases. And we realized that this was due to some problems in the definition and awareness of pulmonary embolism. This is why we decided to tackle the problem by providing better estimates than in the past using the death certificates, the vital registration data provided by the most authoritative and publicly available source of vital registration data in the world, which is the World Health Organization cause of death database. So this analysis, the global scale of pulmonary embolism mortality, was the culmination of this project, but it is also a starting point because we proved that we have better data than in the past, but we still have too much heterogeneity and we need to work on better data and more data in the future.
Thank you. Talking about the accuracy of the identification of PE-related death in this database, can you explain how accurate is your method to identify PE-related death in the WHO database? I remember you mentioned in your paper previous work performed by your group with DVT and death associated with DVT. Can you tell us more about that?
Yeah, absolutely. So this was actually one of the most important innovative aspects of this analysis and our previous analysis, how we approach the use of vital registration data in the standardized way that all over the world, actually a death certificate is compiled at a hospital. The moment that a patient dies, physicians are able to choose a primary cause of death, which the WHO defines as the condition that unleashed the process that ultimately led to death, and several concomitant causes of death that follow the primary cause of death in a causal chain. This poses a specific problem for pulmonary embolism because pulmonary embolism can follow conditions that are primary causes of death in their own regard, such as cancer or surgery or traumas. This makes it very difficult to provide accurate estimates because in different countries or in different institutions, physicians may always choose cancer and underlying cancer as the cause of death. In other institutions, in the presence of risk factors for other cardiovascular diseases, death may be attributed to myocardial infarction. So we were left with the choice of only using the cases with pulmonary embolism as a primary cause of death, which would probably have underestimated their mortality, or using pulmonary embolism mentioned in any part of the death certificate, which would have overestimated probably the deaths, because pulmonary embolism can be a marginal event in a patient with cancer, for instance. What we decided to do is to also include, to only use pulmonary embolisms mentioned as a primary cause of death, but also include the death certificates that used venous thromboembolism in general as primary cause of death. This was based on indirect evidence that these patients probably had pulmonary embolism. If lymph vein thrombosis is mentioned in the primary cause of death, that is unlikely to have caused death without a concomitant pulmonary embolism. And subsequent statements from the ISTH are consistent with this approach.
Thank you. Talking about the ISTH, so the ISTH recently published a definition for PE-related death and classification of the cause of death in VTU studies. So when you use this definition in an autopsy cohort, it showed a very high specificity, a moderate sensitivity, and a good inter-rater reliability, which is very good for our studies. But do you think these criteria can be implemented in database studies such as yours or adapted from information available in death certificates?
So yes, we are all throughout our analysis, we have been aware of the several statements in the last few years by the working group in the STH, and they were published by Dr. Trishla, our colleague Tobias Trishla. And the most recent work is this validation, which has been published only a few weeks ago. So the problem is that that is a clinical definition of the cause of death. And we work with something that happens afterwards, which is the death certification. So it is a challenge to spread the use of this standardized now definition of the attribution of cause of death to clinicians all over the world so that death certificates are more correct. However, the main assumption we made in our analysis is perfectly consistent with this definition, because now the notion has been made formal that, as I already mentioned, indeed, even in the absence of direct imaging proof of pulmonary embolism, if pulmonary embolism is the most likely cause of death because the patient had indeed deep vein thrombosis, then death from pulmonary embolism can be assumed. And that avoids the systematic underestimation of mortality from pulmonary embolism that we had in previous older research.
That's right. One last question for you. What are the next steps for your research or the research overall in the epidemiology of PE-related death?
Two things, two steps forward. The first is more data, and the second is data of higher quality. And we think that both goals will help each other, because as more data made available, more awareness comes on the need for data of higher quality. And we especially need data from lower and middle income countries to get a better grasp of the different geographic difference and determinants of pulmonary embolism. And in this perspective, better data, more data, all initiatives that contribute to the awareness of pulmonary embolism and its role as potential cause of death, such as the World Thrombosis Day, will be pivotal in the development of our knowledge.
Thanks again. And thank you for presenting your work and giving us more insight into this very interesting and important topic. We hope viewers will read the full details of your paper on our site, rpth.isth.org. And Dr. Valerio, I hope you will publish again in RPTH. Thank you for watching and keep an eye out for the next RPTH recap.
Thank you.